Rohit, just give us the countdown when we can go live.
Yes, sir. Sir, we are live in 5, 4, 3, 2, 1. We are live now, sir.
Good evening and welcome to Win India's World Kidney Day educational webinar on kidney failure care for all, bridging the gaps in low resource settings. Today marks the culmination of a vibrant week of activities that were undertaken to celebrate World Kidney Day by Women in Nephrology India. In this evening session, we have with us, as you can see, Gents in Nephrology, who kindly consented to join us and share their perspectives. We have a keynote address followed by a panel discussion. I would like to extend a warm welcome to Dr. Vivekanand Jha, who will be joining us soon, and he's going to deliver the keynote address that is titled Challenges of Kidney Care in India. Professor Jha, as each one of us know, has been the immediate past president of the ISN, is the executive director of George Institute Delhi, chair of the Global Kidney Health, Imperial College London, and importantly, Sir has been very supportive towards professional growth of women nephrologists in India, and he was the one who introduced me to the ISN and the ISN to me. And in 2012, I remember that he was the one who organized the first meeting to promote Women in Nephrology initiative. He's been an inspiration to each one of us, and we shall now request the organizers to play the recording of his talk.
Good evening, everyone. Let me start by thanking the organizers of this meeting, the team at St. John's Medical College, Bangalore, for inviting me to come and join you in marking this World Kidney Day. What the team has done is to ask me to give an overview of kidney care in India at the moment and discuss some of the challenges, but also some possible solutions. Even as we observe the World Kidney Day on March 10th, 2022, let us remember that different parts of the world are in conflict, and war and different other types of deprivation are depriving a large number of populations around the world of their basic human rights. And they have many, many more urgent issues to contend with. So as humanity, we need to stand in solidarity with all of them and remember the sufferings that they are having to go through. Now, if we look back into the history, and if you somehow went back to 1950 and picked up the textbook of medicine, and this was the textbook of medicine popular at that time, you would find that the authors note that the treatment of uremia is wholly palliative, and amongst other things, the use of peritoneal lavage or some form of artificial kidney had just been started to be talked about. If you move fast forward from there and come to the year 2006, when World Kidney Day was actually proposed and established, the editorial, which now makes its appearance every year since the year 2007, said that chronic kidney disease was common, it was harmful, but most importantly, it was treatable. And that is the message that World Kidney Day has been consistently delivering year after year after year. And we need to make sure that this message is presented to all the stakeholders around the world so that we can achieve equity in kidney health. Also, just for the sake of recounting some of the history, these are pictures from the dialysis system that was set up by Professor K.S. Chugh, my mentor at the PGI Chandigarh. And for the youngsters amongst you, the picture on the left is artificial twin coil dialyzer, the Pulse kidney. And here you have a visitor, Dr. Samuel Kunz, who came to Chandigarh in 1970s, and he is with amusement looking at the overhead tank which was used to feed dialysis fluid to the dialysis machine. And here on the left, you can see a child getting dialyzed by the Keel plate dialyzers. And on the right, you see a peritoneal dialysis catheter, which we used to make ourselves by punching holes into a PVC tubing. And this was the trocar we used to make a hole into the abdomen of people and put in this tube for peritoneal dialysis to get access. Now, we should also take a moment to remember that all the progress that we are seeing today has been possible because of the work of a large number of pioneers, and only a few of them are shown here on this slide. Many of them have left now and are no longer with us. But we, as Newton said, we continue to observe by standing on their shoulders. So what has happened over the years in Indian nephrology? Demand has grown, the scope and range of services has grown, the workforce has grown, but still remains far, far less than what is needed. There has been progress in financing of kidney care, but then just like financing in all aspects of healthcare, we need to do more. We need to look at what is happening in the governance and administration of healthcare, specifically kidney care, and data sharing, communicating with ourselves, and generating new knowledge through research. We live in a world which is driven by the Sustainable Development Goals, to which almost all the member states of the United Nations and the WHO have signed up. And the Sustainable Goal number 3 is the goal that relates to health and well-being. But as has been pointed out by a number of leaders, including Dr. Valerie Lux, that most of the Sustainable Development Goals are relevant to kidney health and health in general. To achieve all the targets articulated in the Sustainable Development Goal number 3 and other targets, we need to look at the health systems building blocks. And here on the right in the figure, you have the various health systems building block laid out. And when we think of delivering kidney care, we need to keep those in mind. But that needs to be underpinned by certain principles, and those are the principles of solidarity, social justice, universal access, multi-sectoral action, community participation, everything underpinned by the values and principles of our society. If I had to pick out the 2 points from the Sustainable Development Goals that should guide our actions, they are these two. One is the commitment to reduce by 1/3 the premature mortality from NCDs through prevention and treatment. And the second is to achieve universal health coverage, including financial risk protection, which is so very important to our patients with kidney disease. It is one of the worst kept secrets in global nephrology that there is a huge unmet need in kidney failure worldwide. According to a systematic review that we now published almost 7 years ago, a huge proportion, in fact, a majority of patients who develop end-stage kidney failure around the world every year are not able to receive the kind of treatment which is accessible easily to people living in high-income countries, just because this treatment is either not available or not accessible or not affordable by them. We also now have data that mortality due to kidney disease is increasing. It is increasing around the world, in fact. Kidney disease is the 3rd fastest growing cause of death worldwide, but it is specifically increasing in India. And here is data from the Million Death Study, which was published in the Lancet Global Health about 5 years ago, which shows you can see the proportion of kidney failure related deaths in the years 2001 to 2003 on the left and 2010 to 2013 in the right. And I don't have to read the numbers. You can see by the change in colors, the rise in the proportion of kidney failure deaths during the course of the decade. This is the summary data around the delivery of dialysis, to which conversation around kidney care often gets reduced to. That according to estimates, about 210 to 250,000 new patients develop kidney failure every year. So if dialysis was universally acceptable, we would assume that there will be between 1 and 1.5 million people on dialysis in India. But in contrast, there are just about 1/10 to 1/15 of those people who are currently on dialysis. We know that dialysis funding is largely self-paid at this particular point of time. and a majority of dialysis is given through in-center hemodialysis approaches. We also know that the kidney disease risk factor burden is rising across India. And the two major kidney disease risk factors are diabetes and hypertension. And there have been numerous projections which have been given for these two conditions, which document the rising prevalence of hypertension and diabetes. And also, as the surveys are done, they identify more and more people with undiagnosed and suboptimally treated hypertension and diabetes. A new type of kidney disease that has emerged in India and many other parts of the world over the last about 15 to 20 years has been dubbed as chronic kidney disease of uncertain etiology. And as the name suggests, we don't fully understand why this chronic kidney disease develops. Initially described from the Srikakulam district in Andhra Pradesh in the eastern coast of India, it has now been reported increasingly from many other parts of the country, and this particular picture shows you the various places identified by these pins from where nephrologists are reporting clusters of chronic kidney disease patients presenting in whom the cause of disease is not clear. And we need to do a whole lot more research than we have been doing to identify this, because this is slated to grow further. We did one such study actually in Uddanam, where the original CKDU has been reported from. And in this study, which was done in 67 villages in 2,419 patients, we found that chronic kidney disease prevalence was as high as 21%, out of which just about 10.25% had EGFR less than 60 mils per minute, and about 15% had elevated urinary protein creatinine ratio. We identified that presence of a positive family history of chronic kidney disease, hypertension, and tobacco use were independently associated with increased risk of developing chronic kidney disease. And then there were a number of other risk factors also which were identified, for example, occupation as a laborer and farm worker, lower BMI, poor education, and presence of heart disease. We found that in addition to kidney disease, the prevalence of hypertension in this adult population was 42%, 13% had diabetes, and 14% had a family history of chronic kidney disease. I have already told you this data about the prevalence of kidney disease, but even more strikingly, 9 out of every 10 people with chronic kidney disease did not know in this area, which is described as a high prevalence area. So people should be already aware, but they still did not know that they had chronic kidney disease. As I said, this phenomenon is not limited to Andhra Pradesh or to Uddanam. This is a publication from Punjab. And in Punjab, these authors did a survey which was identified by the WHO STEPS mechanism. And they found that the chronic kidney disease prevalence was again 48%, with albuminuria actually vastly outnumbering the proportion of people who had low EGFR. What is the consequence of this chronic kidney disease? Apart from a deterioration in the overall health condition, there are compelling data to show that people who develop chronic kidney disease, especially advanced kidney disease requiring dialysis, experience catastrophic healthcare expenditure. And this is data from Kerala, which is one of the states where healthcare is better organized and public funding is much better than many of the other Indian states. And the discussion around catastrophic healthcare expenditure in patients with chronic kidney disease has often been focused on dialysis population. But we showed in a recent paper that people with non-dialysis requiring chronic kidney disease, which is early stages of chronic kidney disease, also experience catastrophic healthcare expenditure. And as you can see in the top row here, that about 40% of people with early stage chronic kidney disease also needed to resort to distress financing, which means that either they had to take a loan or sell some of their assets or indulge in some of the other practices which would otherwise normally not be acceptable in terms of their financial situation. Despite all of this, we have a lot of work to do to improve outcomes. This is data from the Andhra Pradesh Arogyasri dialysis program, where we looked at the survival of patients who were getting free dialysis, again, as part of this Arogyasri program. And we showed that less than 50% of the patients continue to be on dialysis after about 6 months, which is a dismal survival rate. The number of people who were recorded to have died was relatively small, but a huge proportion of people actually dropped out for reasons that need to be ascertained much more clearly. So if we try and identify the treatment gaps for kidney disease right now, I think we can be convinced that there is a rapidly changing disease burden. We have a large undiagnosed and untreated population of kidney disease in India. I didn't discuss this data, but I think we all know by just looking around ourselves that the workforce to manage this large load of patients with kidney disease is suboptimal. And we hugely depend on a model of care that is centered around a doctor. We have a hugely disproportionate focus on curative care, such as dialysis. But what we need more is effective, organized community programs for detection and treatment. And once we have identified these people, it is our moral imperative that they receive appropriate guideline-based care. And in terms of guideline-based care, there is a lot that we can do. And these are measures that, again, are not unknown to you. And these measures include non-pharmacological interventions, including lifestyle modification, cessation of tobacco use, and also control of risk factors like blood pressure and blood sugar. Specifically, now we have tools over the last 2 years that specifically can retard the progression of chronic kidney disease and or development of complications, such as SGLT2 inhibitors and mineralocorticoid receptor antagonists and so on, which have now bolstered our therapeutic armamentarium, which was limited to angiotensin receptor blockers for 25 years, and for the last decade or decade and a half also included statins. But then we need to start somewhere. So where do we start? We need to reconceptualize our workforce so that we move away from a physician-centric model to a non-physician healthcare worker-based healthcare delivery. They need to be supported with technologies because they have not been trained to provide care. But technologies provide a unique opportunity for us to augment their capacity in a relatively short order. India is the generic drug industry and generic drug capital of the world, but we need to continue to innovate and develop further low-cost drugs, which would include fixed-dose once-a-day combinations, and in future, perhaps implantable drug-device combinations and so on. We, through our research, have shown that this approach actually works. And we showed in a study which is now 10 years old that healthcare workers, when given a checklist, they were able to identify individuals who were at high risk of developing cardiovascular disease and its complications much better, 12 percentage points better than primary healthcare physicians who did not have access to such a checklist. We also showed that when we implemented a primary care model, which was centered around non-physician healthcare workers who were supported by technologies such as use of a clinical decision algorithm, they were able to improve the proportion of patients with hypertension who were on appropriate blood pressure lowering medications and had achieved target blood pressures quite substantially. So this is something which is possible, but we need to scale it up, and we need to scale it up in combination and in collaboration with our other stakeholders. Now, the next thing I would like to talk about is the need to generate evidence. It is often said that half of what you are taught in medical school is wrong. The trouble is we do not know which half. And let me illustrate this with just one example. This is work that was done by Dr. Vinayak Prasad and Dr. Adam Seafour from US, in which they looked at more than 2,000 publications that tested a medical practice. Those medical practices could be new practice or could be an established practice. So let's concentrate on this last one, because the point that we are trying to make is that an established practice can often be drawn. So some of these established practices, for example, use of corticosteroids in patients with IgA nephropathy, it is fairly well established I'm sure you would agree in practice without strong evidence for it. So different investigators around the world put these established practices to test. What happened is that they found that as many as 40% of these established practices were either no better, or they were in some cases even worse than the conventional treatment, which would have been without these established practices. And another 21% were inconclusive. So just about 40% or less than 40% of these established practices were confirmed. What the point that I'm trying to make is that we need to do more such studies to increase and augment our knowledge of evidence-based approaches. But sadly, this kind of slide has been shown in multiple nephrology meetings, which shows that nephrology lags behind many other disciplines in performing these kind of randomized clinical trials, which we need to get better about. But there is good news from India. PubMed listed clinical trials in kidney disease have been increasing in India, and you can see over the last 20 years. In the last 4 to 5 years, there has been a significant increase in the number of PubMed listed clinical trials, which is all good news. We need to augment these clinical trials through the other kind of research, which is implementation research. And implementation research asks the questions: how can we take an established or effective treatment approach to the people who are likely to benefit from it the most? There are a number of approaches to doing implementation research, and we need to, as nephrology community, get better at doing these kind of research approaches. But this requires us to step out of our comfort zone, engage with other stakeholders, which include policymakers, program implementers, and members of the community. Now, we are hopefully just emerging out of 2 years of long beating by the virus called SARS-CoV-2, which led to this disease called COVID. And kidney care is likely to be different in the post-COVID world than it was more than 2 years ago. Some of the focus, and this is something which is not necessarily limited to kidney care, but can be applied to many other chronic diseases. Increasing use of telemedicine, increasing use of point-of-care diagnostics, use of online patient education and awareness platforms, in line with the primary healthcare, non-physician, community health worker-driven models, more focus on self-management, self-health management enablers, and of course, going forward, use of affordable medical devices and more and better use of electronic health records and analytics. As a nephrology community, if we have to serve our patient community better, we also need to get better on these two other elements, which nephrologists have often ignored, and these are shared decision-making and kidney supportive care. We need to work with our patients to identify the treatments that align most with their values, and then offer that treatment, make sure that it gets to them in a manner that makes their lives better, which could include increasing use of kidney supportive care. Kidney supportive care is now a movement in many parts of the world, and we need to do more of it in India to improve the lives of our patients. Again, coming back to COVID, COVID has taught us that we need to be aware of the health challenges of the future. And there are going to be a number of health challenges related to population growth, related to industrialization, related to the geopolitical problems that I mentioned right at the top of my talk. These global challenges will be compounded by the changes in global trade, erosion in biodiversity that is occurring as a result of climate change, which is forcing migratory movements and degradation of ecosystem. All this has already led to reemergence of infectious as well as non-infectious diseases. Climate change is particularly relevant to kidney disease. We are aware of a variety of health-related kidney disease, some of which might be responsible for the so-called CKDU that we are seeing increasing around the world. Kidney diseases will develop that are related to the changing biodiversity and also extreme weather events. Now, it's already happening, and these are data from Australia, which looks at the relationship between maximum temperature and hospital inpatient renal admissions from a variety of conditions, which you can see in the two charts. And I don't have to point them out to you to make the point that as the temperature increases, admissions for various renal indications goes up in hospitals. We also need to become better in using data. So there is now increasing amount of data being generated through a variety of mechanisms. There may be insurance data, there may be health claims data, there may be electronic health records, and we need to use analytic approaches to improve our understanding of human health, human science, and develop early warning systems, detection and tracking mechanisms. And we have been often now reminded that we need to do more of things like genome sequencing, etc., to identify how the pandemic that we are currently living in is going to behave and evolve. As I said before, in terms of doing more around research, we need to build capacity for research in our community. This research capacity strengthening needs to involve all stakeholders. It needs to have a bottom-up approach from the community itself, but it also needs to have top-down approach, which means there needs to be commitment from funding agencies, from institutions, and from leaders of professional societies that we do need to invest more in research capacity building. This will require development of partnerships between academic institutions, partnership between academia and industry, and partnership between academia and members of the community, which need to organize themselves better. To make that happen, we as leaders need to encourage and retain researchers. We need to invest in development of a research career and convince our young researchers that there is an attractive and viable career path as a researcher, and they don't have to necessarily spend a disproportionately large amount of time in clinical care. We need to measure their performance and reward them for the good work that they do. With that, my dear friends, I would like to end by showing you the slide, which is not a typical conclusion slide, but it presents to us the various elements that will impact how we deliver kidney care to our community and make sure that this kidney care is embedded within the existing healthcare system and integrates with other kinds of healthcare challenges that we will face going forward. And the overall goal of all the endeavors should be to keep our populations healthy, to tackle the dual challenge that our humanity is facing, which is the combination of environment change and climate change and non-communicable diseases. This has been reinforced in the IPCC report that came out just last week. We need to make our healthcare delivery systems much more resilient and increase the culture of global health governance. We need to become much more efficient at the use of healthcare technology with the goal of eventually coming back to the message of the World Kidney Day, which is to deliver healthcare for all in an equitable manner everywhere around the world. With that, I will end my presentation. Thank you very much for your attention.
We are grateful to Professor Jha for this important keynote address that highlighted the gaps and important aspects of how we could invest our efforts towards improvement in all domains, clinical, training, and research. Unfortunately, he is not able to join us at this point in time, and we will therefore move ahead with the panel discussion. And before we begin, I take pleasure in inviting the panelists. Let me start with Dr. Sarala Naicker. She is the Professor Emeritus of Medicine, Chair of Graduate Studies and Research, University of Witwatersrand, Johannesburg, South Africa. She's been the past president of the South African Renal Society. She's chaired several committees under the ISN and has been also a member of the KDIGO committee. On a personal note, Dr. Naicker has leadership skills which she carries with admirable poise and elegance. She's an eloquent speaker. So welcome to you, Dr. Naicker. Dr. Valerie Lukes, nephrologist from Zurich, and she's sitting in an HIC, but she's got several fruitful collaborations with teams in low and middle income and low income countries in Africa. She's known for her expertise in public health, works closely with the WHO, has a PhD in biomedical ethics and law. And now she is extremely busy looking after babies, neonates, and an 800-gram neonate who is undergoing a peritoneal dialysis. She is the deputy chair of the advocacy working group of the ISN. And again, on a personal note, she has been an ISN mentor to me, and she's known for her principles, dedication, and integrity. Welcome, Dr. Valerie. Dr. Lloyd Vincent. He's the director and co-founder of African Healthcare Network. He has strived over the past decade to establish renal care systems in several countries like Rwanda, Tanzania, and Kenya. But he's originally from Bangalore, and he was the head of nephrology at St. John's Medical College Hospital 2 decades ago. When I was a trainee, and I still remember that he was one person who encouraged close interactions between adult and pediatric nephrology. Welcome to you, Dr. Lloyd. Dr. Urmila Anand, senior consultant nephrologist and head at Yashoda Hospitals, Hyderabad. She's active on various committees of the ISN and is the present dynamic president of the WIN India. I was fortunate to be under the tutelage of Dr. Urmila, and during my initial years of training at St. John's again, and we used to look upon her as the walking textbook of nephrology. Welcome, Dr. Urmila. Dr. Priya Paez, a good friend and colleague with whom I have shared many laughs and fruitful discussions. Priya holds a diplomate of American Board of Pediatric Nephrology, and then she shifted gears to return back to her home country, and she's been with us for nearly a decade and an asset to our department. Besides her expertise in pediatric hypertension, she has created a niche for herself in areas that are untouched with respect to pediatric CKD care, and those are bioethics, health economics, quality of life assessment, and qualitative research. She hones leadership skills as she played a very important role being the director of the Sister Renal Center program in collaboration with Ethiopia, and is a member of the outreach committee of the International Pediatric Transplant Association. I now hand over the floor to Dr. Priya.
Thank you so much for introducing everybody. I'd like to just start by saying a very big thank you to all who have joined our panel discussion. I think I'm really feel fortunate to have such a wonderful panel of experts in nephrology, pioneers in the field of nephrology, public health, aspects of kidney care, and also in ethics in nephrology and nephrology education. So I'm not going to waste any more time, but I'm going to jump straight in. I'm going to start sharing my slides now.
Yes, go ahead.
Okay. So if you see my slides, if you don't, just let me know. So this is going to be a panel discussion focused on the theme of World Kidney Day. Kidney failure care for all, bridging the gaps in low resource settings. This session will be a story in several scenes of typical patients that we see in various low middle income countries, and probably also encounter problems that are seen in both high income and low income countries. And as the story plays out, I'm going to stop and ask our panel questions. Audience, we do welcome your interactions, and please put your questions in the chat box. We'll try and answer them, your questions, as well as address any comments that you may have as well. So before we begin, any slides, any stories, and any questions, I'm going to begin with a story of a patient with a video. So a brief, to just tell you what's happening here. This is a video made by JIPMA in Pondicherry, which is a government, a very well-known public funded hospital and medical research center. And this is one of their first PD families. And I say families because this is the parents of 2 children who they began on PD. And I think this video is very illustrative of scenarios that we see in low resource settings. It shows the poorest of the poor and how they overcome adversity. Our patients, we are a big PD center in St. John's, but being a private center, we probably don't see the type of patients and the type of housing and conditions that you will see in this video. So I'm going to begin.
எனக்கு 3 பிள்ளைங்க இருக்குது. 2 பிள்ளைங்களுக்கு உடம்பு சரியில்லை. ஹாஸ்பிட்டல்ல சிக்மல கொண்டு காட்டுறதுக்கு கிட்னி ஃபால்ட்டுமா மாத்திரை வாங்கி சாப்பிடுமா அப்படின்னு சொன்னாங்க. 2 வருஷம் மாத்திரை வாங்கி கொடுத்தேன். மாத்திரை வாங்கி சாப்பிட்டு வந்ததுங்க. 3ஆவது வருஷத்துல உடம்பு ரொம்ப அதிகமா போச்சு. வந்து ஆபரேஷன் பண்ணி பேக் போற மாதிரி வைக்கணுமா டீ போய்க்கணுமான்னு சொல்லிட்டாங்க.
If accepting the reality of permanent kidney failure for 11-year-old Archudha was difficult on her parents, their troubles were far from over. During this period when they were engaged in the care of their daughter, Archudha's elder brother Silambarasan, aged 14 years, developed similar symptoms and was brought to Jipmer. Tests conducted on him revealed that he was also suffering from the same disease which affected his sister and had
So that was a short clip showing you, I guess, triumph in adversity. This next clip before we start is a brief clip, but it is special because special to all of us celebrating Women's Day recently and for women in nephrology. This is a woman patient who was very frightened of doing PD when she was diagnosed with kidney failure. And it just shows you how she, in her very humble settings, balances her family care and also does PD for herself.
என் பேரு புவனேஸ்வரி. இன்னைக்கு இந்த கிட்னி ஃபெயிலியர் வந்து 3 வருஷம் ஆகுது. எனக்கு பசங்க 2 பசங்க இருக்கிறாங்க. எங்க வீட்டுக்காரரும் வேலைக்கு போகல. நானும் அவங்களையும் அனுப்பிச்சிட்டு இந்த டயாலிஸ் பண்ணிட்டு தான் இருக்கிறேன். மற்றபடி எனக்கு எந்த தொந்தரவும் இல்லை. ஹாஸ்பிட்டல்ல கத்துக்கிறதுக்குள்ள கொஞ்சம் கஷ்டமா தான் இருந்துச்சு. வேண்டான்னு தான் சொல்லிட்டு இருந்தேன். அப்புறம் மறுபடியும் முயற்சி பண்ணா சரி வரும்னு சொன்னதுனால நான் இதை கத்துக்கிட்டு இப்போ நல்லா நார்மலா வேலையும் செய்யறேன். வீட்டு வேலையும் பாத்துக்கிறேன். பசங்களையும் ஸ்கூலுக்கு அனுப்ப எல்லாமே செய்யறேன். அதனால எனக்கு இந்த டயாலிஸ் கொஞ்சம் ஈஸியாவும் இருக்கு.
So with that, I'm going to now summarize these strengths of kidney care in low middle income countries. We're going to hear a lot of problems, but let's not forget that in addition to problems, we have tremendous strengths. So the first, of course, is that nephrologists are vastly experienced. We have huge patient load and very adept clinical practitioners. The second is that there's a direct connect between nephrologists and the communities and primary healthcare workers, which is not often seen in high-income countries where nephrologists work in referral centers or in specialized dialysis centers. The third is a spirit of innovation, ready to try new things, and a strong desire to make things better. Next is the close patient and family relationships. Invariably, physicians get emotionally tied to their patients. We try our best to do our best for our patients despite the adversity. A big feature of Indian families and families in many other low resource settings is the strength of women who accept a lot of burdens, including illness and caring for those who are sick themselves. Despite all the challenges, in low middle income countries, the outcomes of kidney transplant are excellent. And so therefore, transplant remains the best treatment for kidney failure, even in low resource settings. And we should not forget that, because that should be our aim. In general, patient families are strong, they're resilient, and they're close-knit. And so therefore, let's jump straight into our first scenario, coming from a position of, I guess, optimism. So kidney failure care for all essentially encompasses accessibility. And when we talk about accessibility, we will talk about the various factors that contribute to accessibility, such as the availability, affordability, acceptability of care, advocacy, equitable care, innovation, and awareness of kidney disease, and awareness of treatments that are available as well. So jumping straight into scene one. Scene one, we have a large private sector teaching hospital, a referral center for CKD and kidney failure care. A 50-year-old man presented with edema, symptomatic uremia, and echogenic kidneys. He was diagnosed with hypertension 15 years ago, but was never evaluated or treated. He came from a rural background. He farmed a piece of family land and was the sole earner for a family of 4. Hemodialysis was started urgently, and because he had kidney failure, he was advised maintenance dialysis. The patient lived 250 kilometers away from the hospital. And he asked, and so did his family, what type of dialysis is available. So when we talk about dialysis, I think there is a difference in the availability of dialysis in LMICs and high-income countries. For the most part, high-income countries have universal healthcare coverage for dialysis, whereas in low-middle-income countries, dialysis services are provided differently in the public sector, which is government-funded and therefore free to patients, and also available in the private sector, perhaps more available in the private sector, but for this, the patient has to pay out of pocket.
Priya, just to let you know, Dr. Jha has joined. Thank you very much, sir, for joining us.
Great. Thank you, sir, and welcome. I'm going to see if I can see you on the screen. Yes, I do. So if you don't mind, I'm going to ask you the first question, Dr. Jha. I wanted to ask you about the your opinion on the availability of dialysis in the public sector. What are your comments on how easily available it is for patients?
Well, thanks, Priya, and apologies for not being able to join sooner. My internet connection has been quite dodgy for the last 24 hours, and I had some difficulty finding a stable spot. So, look, coming to your question, it's not a question, this question really doesn't require an opinion, but it requires us to base our answer on facts. And the facts are that availability of dialysis in public sector is quite heterogeneous in India and perhaps in many other countries with similar socioeconomic settings. Even when dialysis is theoretically available, it may not be accessible to patients because of the reason that you mentioned, because the patients may live far away. I think there was a study which looked at the average access, and it turned out that almost a quarter of patients lived more than 100 kilometers away from their dialysis center, and more than 50% lived more than 50 kilometers away. So it's a substantial challenge. Many of us worry even about our daily commutes to work, and so which may be a few minutes. And so we can imagine the plight of a dialysis patient when they have to travel such long distances just for survival. And this was something which came to the fore during the COVID-19 pandemic, when a large number of patients were unable to access dialysis. So that's just one. Second is just because there are a few dialysis beds in a public sector hospital doesn't mean that they will be available to a patient who needs them. Those beds may be full, or because there may be other type of limitations that prevent these people from coming to getting dialysis. Now, the last point that I would like to make is that even if the bed is available and a spot is accessible to a patient, that does not necessarily mean that this patient now has access to good quality dialysis. And we showed that in our analysis of the Aarogyasri program, in which, as you said, Priya, patients had access to free dialysis at a point of care. So if they could reach a dialysis center, they would be given free dialysis. But even in that program, we tracked patients over a 5-year period. Average patient survival on dialysis. When I say survival, I mean their stay on dialysis was less than 6 months. So more than 50% patients dropped after the first 6 months of dialysis or died. And when we say they dropped, it is equivalent to death in our Indian setting. We all understand that. So there is a lot that we need to do just beyond even thinking about making dialysis accessible. We have now a national dialysis program which talks about providing 8 hemodialysis beds in each district hospital. And we did some math and published it in an editorial in the journal Nephrology. This would, even if all the districts miraculously tomorrow had all the 8 dialysis beds, this would be sufficient only for 1/10 of the number of patients who require dialysis in India. So I think we have a long way to go to provide public dialysis to our patients in India. We know that the government of India has actually also recently approved peritoneal dialysis to be covered under publicly funded dialysis program. But setting up a peritoneal dialysis network is a logistic challenge. This is not to say that this logistic challenge cannot be overcome. And several countries like Thailand have shown examples of how this can be done by using public networks. For example, the postal network for delivering dialysis fluids and frontline healthcare worker-based monitoring programs to monitor quality of care and the quality of dialysis. So all of these things can be done, but it requires discussion, it requires resource, it requires research, and more than anything else, it requires us to engage very, very closely with the community. And when I say community, I mean the entire stakeholder community, starting from policymakers to implementers, to community members, to frontline healthcare workers, and of course, to nephrologists. If I had to pick 2 barriers to accessible dialysis programs in a country's sustainable dialysis program, they would be policymakers, and the second one would be us, nephrologists.
That's on that note. So thank you for highlighting the challenges of public sector dialysis, but also telling us that it's really the way forward, I think, if we want to provide good, not just good dialysis, but also ensure good patient outcomes. But as it is now, and I'm going to ask Dr. Urmila, ma'am, the next question. Can you tell me, in your setting or your perspective working in a private sector corporate hospital, how different is it? How does the private sector dialysis, how is it better than the current government sector dialysis right now? What is its strengths?
As Dr. Jha said, I mean, that question also, I think the answer is there. We cannot really say that the private sector is better than the public sector, because the question is again accessible. We may deliver good quality dialysis, but how many patients can access this quality of dialysis? That's one. We may have, as Dr. Jha said, beds for patients on dialysis 24 hours. We may give them the best quality, but that is not the answer at the end of the day. And in your situation, the patient is 50 kilometers away. So I may give a dialysis for him. I may get him better, get him out of the emergency with his emergency dialysis. I send him back to a center nearby. I work in Telangana, and Dr. Jha knows about it. And the Aarogyasri paper is actually mentions the data from Telangana. We send our patients back, and no doubt they get thrice weekly dialysis. They get heparin. Dialysis is now, they have non-reuse dialysis. All this is fine. But at the end of the day, And it doesn't also need nephrology care. It actually needs to see follow-up. Is that quality important? Because most of the things that we see is, even though we dialyze them, they're back to us every second 3 months with an admission, as an emergency admission. And also this dialysis in districts or dialysis in villages close to you offers dialysis. The vascular access program, the problems with other medical issues are not dealt with. So I don't think I deliver any good dialysis. I just cover them up temporarily, get them out of the emergency, private sector. If the patient is privileged, is in a metropolis and can afford dialysis, they can come to us thrice weekly, or they get transplanted. But 90% of our patients go back to the districts and the villages, and they are followed up in villages. We see them only when, again, this kind of emergency happens.
Thank you, ma'am. I think that it's definitely, as you said, more than just having the machines available. It takes a village, I guess, to treat somebody in a rural area. So we've been talking a lot about the setting in India, and I'm going to now knock on Dr. Sarla's door, and to give us another low resource setting perspective. In your setting, ma'am, would maintenance dialysis, if all other characteristics of the patient were similar, would maintenance dialysis be available to this patient in your setting?
Thank you very much, Priya, and thank you to the organization for inviting me to be here. I think, as I mentioned, this is a very common scenario globally. And I think our situation is very similar to what we've heard from Vivek and Urmila. South Africa and Africa as a whole has great inequities. We're a very unequal society. And let me talk about South Africa as a situation that I know very well. We basically have a two-tier system, very much like you have in India. So people who get accepted for public sector dialysis have everything free. And people who can, by one means or another, get onto medical insurance, dialysis or kidney replacement therapy is considered a prescribed minimum benefit. So the medical insurance will pay for dialysis. So having said that, this particular patient would be looked at for public sector dialysis in South Africa. And the way one sees it from the case history that was presented, he should be highly eligible. But having said that, can he access treatment, as Vivek said? While the treatment is free, the amount of dialysis is kept by the budget of the hospital. So what we find is the demand for dialysis totally outstrips the need. And therefore, it's actually a very difficult scenario. And that's something that nephrologists are grappling with all the time. So all things being equal, this patient would be offered peritoneal dialysis as a holding measure while we try and get transplantation done, because we know that with him being so far away, it will cause untold burden to him and his family if he remained on dialysis long term. And just to tell you about the inequality in South Africa, our recent South African renal registry showed that the treatment rates in the private sector are 788 per million of the population, whereas in the public sector, we are treating 57 per million of the population. Now, what you need to bear in mind is that the private sector treats 20% of the population of South Africa. So generally in this situation, if this gentleman were told that, yes, we can treat you in the public sector, but we don't have any slots, what we would do then is try and get a charitable institution to pay for him to get dialyzed in private, while he either is able to get onto some form of medical insurance, in which case he could continue on dialysis, but more realistically is to find a living donor for him so he could get off dialysis quickly. Thank you.
Thank you, Dr. Sarla, for I think we are really highlighting the difference between availability and accessibility of dialysis for our patients in low resource settings. Dr. Valerie, can I ask you? I know your practice setting is very different, but you have really a global perspective. But in your current practice setting in a high-income country, can you contrast how different this would be for a patient who lived where you are? You're muted, Dr. Valerie.
Thank you. And thank you also for inviting me to this extremely interesting and vibrant discussion. I've actually worked in a couple of different high income settings. And so just in general, I would say that a 50-year-old gentleman presenting like this will access dialysis in pretty much all high income settings. I think if I just draw a couple of conclusions, the fact that he was diagnosed 15 years ago and not evaluated or treated actually does happen in high income settings, potentially a little bit less frequently, but definitely does happen. I had experience of a patient in Canada, because in Canada, one actually has the high income, there is social, the government pays for all dialysis, but patients live very remotely. And sometimes if they cannot do peritoneal dialysis, it's an enormous challenge, and families have to drive patients for hundreds of kilometers in very treacherous winter conditions, sometimes for dialysis, which they do. So that's pretty tough. In some places, they actually can install home dialysis in these rural areas. So a patient, if he's confident enough and his family member is confident enough, will actually have a machine. Someone will come in and sort out the water systems, etc. Some of them even have almost like a telemonitor that watches them. They have special alarms if the bed gets wet to detect bleeding and things quickly to wake the patient up. So there are some fantastic ways to facilitate remote dialysis in even in places like Canada where the distances are very far. I think one other thing that often, well, may not be often, probably less now than before, but previously people didn't even think much about PD. I think in lower income settings, one thinks about PD a lot sooner, and I think that's actually being fairer to the patient and more honest. So I think sometimes in the high income settings, it's actually more patronizing to the patient. And very often, especially what I notice in my current practice in Switzerland, is that people are not always often offered PD. Because people just think, well, older patient probably can't even do it and don't often even discuss it. So I think although patients do have access, they may not always get the most appropriate treatment for themselves. And then in countries like Canada with a lot of social support, sometimes it's amazing what one can actually achieve, but the individual cost for one patient is astronomical. But the society decides, that they pay that because that's just part of the social system.
Wow.
Thank you.
That sounds great. I guess one day we'll be able to maybe equalize those differences a little bit. So Dr. Lloyd, I'm going to now change tracks and ask you a different sort of question. We've heard so much about the availability of dialysis and the accessibility varying by where the patient lives. Clearly, this patient was diagnosed with hypertension earlier. He did not get any sort of evaluation or treatment, perhaps because he didn't seek it or that nobody really recognized its relevance. So can you comment on the factors that contribute to awareness of kidney disease and the awareness of the risk factors for kidney disease? You've now practiced in Africa as well as in India.
Thank you, Priya, for having me here, and I thank all the organizing committee, Dr. Alpana and Dr. Urmila for having me here. Well, let me go into the realistics of on the front line as to how we do things out here. I think that will be my perspective. So when we started out here in East Africa, there were no, today we are into 26 centers, but 21 operational centers, and that's studied across East Africa. So that is now we have actually created an access into areas where there was no dialysis. Now, is doing dialysis enough? No, I think that's not the way to go, especially in countries like Africa. We have to have prevention, which is the key, not dialysis. We should have prevention. We should not have people going into dialysis. So then after quite a bit, we said, this is a route that we need to take along with dialysis. So it's not just dialysis centers that we build today, but our aim is to build renal care centers where we have preventive care as well as dialysis. So now we embarked on this matter, and then what happens now? How do we select centers? Now we have now 26 partners, and all of them have been happy with us because it has been a transparent interaction between these organizations, and that is very, very key. You need to have these organizations with you. Now I'm talking of dialysis centers and hospitals that we went into, maybe rural and quite a bit out of the the mainstay in the main African towns. And so when you go into a hospital, first of all, they may not have any renal care at all. So you need to set up the entire system. So how do you set that up? Number one, you need to interact with the hospital management, teach them what the benefits are and how you actually have dialysis, not only dialysis, but you can actually do preventive care. Then you access the physicians or the GPs in there. You actually have to train them, teach them. And if you actually have sessions for them, they learn and teach them how to implement prevention. You get a buy-in from them, and then they contribute enormously. And that is how your whole program comes in. And actually, I on this audience, I must thank all of you all, Vivek, Priya, yourself, Dr. Arpana, Dr. Urmila, Dr. Valerie, Dr. Saranaika, all of you all have come. And you all have all contributed to educating a large section of our people who we interact with. And that is, I have to really take my hats off and thank you all very, very much, because this has made a lot of impact. And a lot of people now become aware of kidney disease in these regions. And then what happens now? How do we go in? So in the hospital, we get in and we actually create awareness programs. We talk to them on CKD prevention. We have actually got dedicated slides that we made. Then we get not all centers can have regular nephrologists. Now, right in Dar es Salaam, maybe we have nephrologists, but outside. So we actually program nephrology visits into these centers. And then these nephrologists go in, they could have camps, they could have awareness programs, they could go around to the surrounding hospitals, and make that awareness known. Because quite often, you see, very close by hospitals may have renal failure, not know that there is dialysis available or kidney care that can be problems that can be sorted out. And this is something we've been doing now for quite some time. So not only within the hospital, but outside, the surrounding regions. And I believe that, on a hub and spoke model over a period of time, we will be able to actually, cover a large ground. For example, in Bangalore city, I remember back in Bangalore, in 1980, when my brother had kidney failure, AKI, there was no dialysis center. But today I know, we have more than 100 dialysis centers and so many transplant and HLA labs. So that's the situation. When we entered Burundi in 2013, you see, there was no dialysis center. And that's when we started AHN. And when we started one center there, today, there are 3 public centers and 2 private centers in Bujumbura alone. So I'm sure with this sort of approach, a hub and spoke model, we will have in East Africa a very, very good program. In addition to that, I think we need to have quality come in. And with quality in dialysis, I think we will revolutionize the entire process in the region. And I think in the future it will come. So beginning with our CKD registry, I think we've started about 6 months actively. And then we said, now we got to go more into the registry and more into follow-up through the registry, through each of these centers. And in the last 6 months, we've got 5,000 patients with CKD, and about 300 patients who are over stage 3. You see, that's where the numbers are. And I think I anticipate that, and Nick anticipates, I think, Nick works, we both work together, and Nick anticipates that we would actually, our projections are about 25,000 to 30,000 patients the next 2 years that we will be handling. So that is how I feel down on the ground. I think it makes a lot of difference. And I think over a period of time, this sort of a hub and spoke model will definitely affect change in the whole region. And I think from the provider perspective, there has been a lot of recognition of kidney disease with the sessions that we have. Now we have trained nutritionists. That's again, awareness creation on the diet in kidney disease in different regions. Our own nutritionists are trained from scratch, and we're getting help from St. John's as well. Then you see, we have nurses that we've been training now from the regions, local regions, that we've trained about 300 nurses across EA. And so I think on the long run, I think this is the way to go. Prevention is key, and it teaches them what is required to be done. and they involve with you. Thank you.
Thank you so much, Dr. Lloyd. I think you touched on very many practical aspects. And so I'm going to move on from the issue of availability, awareness, the need for grassroots education to enhance accessibility now to our next scene. So for this same patient, public sector hemodialysis was not available. So the patient started CAPD paying out of pocket. So his cost was 25,000 rupees a month against his monthly income of 30,000 rupees. So the family used up all their savings. They began to sell their jewelry and land to pay to continue peritoneal dialysis. He was unable to afford the paying for dialysis and his son's college fees. And so therefore the patient's son dropped out of college to take a job. Dejected, the patient tells you that he has no choice but to stop dialysis. I think we come to a very important issue of affordability here. And so, Dr. Valerie, I'm going to ask you to just briefly, we've heard from Dr. Jha in his talk about the importance of universal healthcare coverage. What is the first practical step to advocating to universal healthcare coverage?
So I think when we think about universal health coverage, we have to think about the three pillars. So the first pillar is priority of the disease. The second pillar is the population that should be covered. And the third is protection of people from financial hardship. And essentially, the government should be thinking about every single disease relative to each other. It's a process called priority setting, where when they have a limited budget, to try to extend universal health coverage to as many people as possible, keep as many people as healthy as possible, but also keep as many people out of financial debt as possible, they need to assess every form of disease and decide whether or not it's appropriate. For kidney disease and kidney health, I think the first problem is that until recently, we haven't recognized that it's a priority. But I think exactly as Professor Jha really showed extremely eloquently in his talk, we are realizing that kidney disease needs to be reckoned with. It is very common. It has been very silent until now. And I think the kidney community is slowly starting to publish and to track. As Sarala mentioned as well, the registry in South Africa has very blatant data on the inequities, etc. So I think we need to push for good quality data so that we can show that kidney disease is a priority. And then in terms of the population, I think a lot of countries struggle at the moment when they are low income to decide, do we cover acute kidney disease only if we need dialysis, or do we extend to both chronic and acute, or only treat chronic? These are very challenging, almost ethical questions, because you always leave somebody behind. So the ideal is obviously to try to cover everyone, but exactly as Dr. Lloyd mentioned, prevention, obviously putting a lot of money into prevention, I think should be no excuse. This should definitely happen anyway. And then in terms of preventing financial hardship, we heard again from Professor Jha, there's catastrophic health expenditure, and this particular patient, if you think the definition of catastrophic health expenditure is 40% of the household income after household expenses, etc., or 10% in general, this is almost 90% of this person's entire household income going to dialysis. So catastrophic health expenditure is huge, and chronic kidney disease is the leading cause. I think it's about 188 million people per year fall into poverty because of kidney disease. So all of these things really would qualify kidney disease for universal health coverage. The huge problem, though, is that it's expensive. And so this is where the Achilles heel is. And so my feeling is we need to really advocate and push to try to obviously prevent, to reduce the burden, but also to try to find ways to reduce the price. And that, I think, is a very big elephant as well in the room, is that nobody wants to address the fact that the dialysis industry is generating billions and billions of profit every year. And that I'm not sure is excusable if there are between 2 and 7 million people dying for lack of access to end-stage kidney disease care around the world.
Yes, thank you, Dr. Valerie. I agree that we should put focus on prevention, but once the patient has kidney failure, there should be cheaper dialysis care that's available. So I'm going to this. I think we've covered a lot of this on how expensive dialysis is just now, and that the fact is that patients with universal healthcare coverage have much higher access to dialysis and have better transplantation rates as well. And this just summed up a lot of the work that you all have been doing in this area. So in our own little area of pediatric dialysis, this is a very similar problem. This is basically a theme from our qualitative interviews, where basically 90% of families had not just exceeded the definition of catastrophic healthcare expenditure, but were actually in financial distress and selling personal property. So if we were to summarize this, basically accessibility depends not just on availability and awareness, but also on affordable dialysis that should be sustainable as well as scalable, so that it reaches the maximum number of people. We need advocacy, and therefore patient data is required through registries, as Dr. Lloyd was mentioning. There should be equitable access, as Dr. Sarla was mentioning. Policies for access to dialysis should be transparent. And of course, innovation in sharing means of with primary healthcare workers, as well as of newer forms of dialysis that are cheaper, should be implemented with adequate research as well. So let's move on to the next scene. So as we very often see, a charitable organization agrees to fund dialysis, right? Patient continues peritoneal dialysis. However, he's unable to work anymore. And so therefore the wife takes over the farm work and cares for her husband's medical needs. At a routine PD hospital visit, she complains of frequent headaches, and both the patient and his wife become tearful, but really are hesitant to discuss why. So I'm going to ask Professor Jha to change tracks from patient medical outcomes to patient-centered outcomes. Sir, could you just explain how they are different from medical outcomes? What is the importance of patient-centered outcomes? And I'll stop sharing my slide, I think, if you wanted to see everyone a little bit better.
So thanks, Priya. So look, I think you asked an important question as to what are patient-centered outcomes, and this would require an entire session for itself, discussion around patient-centered outcomes. I think a number of questions can be asked about this patient, and one needs to disengage emotionally oneself from the situation and then ask those questions. What is the health system doing providing dialysis to this patient is really the question that should be asked. And the patients, when you mean patient-centered outcome, again, I'm not sure what you have in mind. Is it just that the patient is alive? Is that a patient-centered outcome? I think now with a number of initiatives such as SONG, etc., it's been shown that patients value the quality of life. Patients value their ability to participate actively in their life much more than just many years of life. And so from this person's story, the way you have described so far, it doesn't seem that at least those outcomes are being achieved. So to understand what the patient-centered outcomes are, we need to talk to the patient, understand that. And look, the conversation around patient-centered outcomes coming from a relatively privileged Western context is somewhat different from what you and I see in our setup. So why do patients want to go on a treatment with all the attendant hardships that they are bringing, both medical hardships, financial hardships, and all the other kind of hardships? So it goes back to the point that Professor Valerie Lux was making around universal health coverage. So what is universal health coverage? When policymakers think about universal health coverage, they don't think in terms of a given individual patient. They think in terms of what they need to do to provide a society with universal health coverage and to be able to do the most good with the available resources, right? So that's the question. And in that framework, some patients will unfortunately fall out of the criteria that would be set for providing a treatment, especially expensive curative care, which is what was dialysis considered as. And so we need to understand what are the life goals of a given patient. For example, this patient is relatively young, and if this patient doesn't have access to a transplant in a reasonably short period of time, what kind of outcomes can you expect with dialysis in this patient with extremely limited resources? So in all fairness, this patient, if we were to make a decision, we would not offer dialysis to this patient, but offer a supportive care. Because in any case, this person is not a productive member either of the society or is able to provide support to his family and take care of any of his life goals, really, and needs that he might have in mind. So this sounds heartless and this sounds unemotional, but I think those are the kind of decisions that administrators and healthcare providers do need to make from time to time, So, and this is not to say that it always will be the case in every single patient like this, but the point is that we need to do it in the context of a shared decision making, as we have repeatedly said. And that shared decision making means sharing all the information that is available with the patient and the decision makers, their family, and then to sit with them and help them make the decision rather than to force a decision on them. But of course, all of those decisions will be made within the context of available options. And that decision about availability of options will be made by providers, will be made by policymakers, ideally in consultation with the society. And so the choices that are eventually agreed on will be widely acceptable to the society, we do hope. So that it's not that as an administrator, they come up with some options which are completely unacceptable to the society. And that is where the tussle comes. Going back to the principle of universal health coverage, and if you look at the Sustainable Development Goal number 3, the Sustainable Development Goal number 3 talks about reducing premature mortality from non-communicable diseases through prevention. So prevention is critical. We keep coming back to prevention and trying to increase access to expensive treatments like dialysis hasn't worked anywhere in the world. And it is a somewhat of a fruitless exercise continuing to chase that goal. We have seen even comments in the chat, and I'm going to be a little bit contrarian here, where provision of single-use dialysis is seen as some kind of triumph. But I would say the only group that is benefiting is dialysis industry, as Dr. Laik said, because they are the only ones who gain exclusively from single-use dialysis because they are selling more dialyzers. There is no evidence so far that I have been able to see convincing evidence that dialyzer reuse is associated with reduced outcome, at least in Indian settings. So look, who are we fooling? I think what we need to do is to really generate evidence and develop policy informed by that evidence. The policy is always informed by evidence, but developed in the context of the society and the resources that are available within the society and the values and preferences that the society sets for itself. It is not always just exactly replicating what has been done somewhere else. I know that I went beyond the remit of your question, but I'll.
No, I think you addressed, thank you, sir. You addressed very many important issues. Clearly, this patient must be feeling terrible. One would imagine that he can't work. He is the sole earner, as has been until now, and that burden has been passed on to his wife and his son as well. And I don't know if I expected you to say that we would stop dialysis and give conservative care only. But I guess that is how perhaps policymakers might look at it. Also, just to highlight here that—
Can I interrupt, Priya? I think it's not just the policymakers, but it is even the providers, us providers, who should look at it that way.
I was too nervous to say
conservative care should be prioritized over dialysis. So conservative care should be available before we make universal dialysis or even start talking about universal dialysis. Because people will always drop off dialysis. This patient would have spent hundreds of thousands of rupees, and after a couple of years period, they will be forced to stop dialysis. I think there is no question in anyone's mind that that is where this patient is headed. And so at that time, this patient should not be abandoned by the healthcare system and should not drop off the radar. but should have access to some service, and that is supportive care.
I agree with you. Thank you. I'm going to, since you addressed a little the caregiver burden as well, I'm actually going to move on because I thought that perhaps this patient would best be benefited. And I think Dr. Sarla had mentioned this in her setting, that a transplant would be in the patient's best interest. So I'm going to move there, but briefly before I do, just touching upon the issue of acceptability. And I think that came through very clearly that what is important to the patient and his family might be very different from what we nephrologists feel should be done. And also, we don't have time, maybe we can discuss it later, a little bit about that the burden seems to fall a lot on the women, the wife who was looking after the child, her husband, and as well as took over the caregiving, medical caregiving, family caregiving. And as nephrologists, we need to be aware, not just the patients need to be aware of disease, but we need to be aware of the need to provide supportive care and perhaps mental health services, all under the umbrella of conservative care, as Professor Jha was saying. So we will move on now to transplant. So this patient was advised kidney transplant as the best treatment for that would be for his kidney failure. So in his region, the average wait list time on the deceased donor organ transplant list was 5 years. And so therefore, living donor transplant was advised for him. Now here's a list of the available donors. He had his wife who was 45 years old and she was diagnosed with hypertension. She was obviously the first person who everybody looked to as the person who would be the possible donor. She was diagnosed with hypertension during donor screening. The next person who was in the family, the immediate family, was the patient's daughter who was 25 years old. She was married and she lived with her husband's family. The son was 21 years old and he was the first in his family to attend college. He was still unmarried. And the last person in the family was the patient's mother-in-law, who was 65 years old, and she was healthy. So I ask everyone here, who would you think you would, either the patient would select to proceed with organ donation, or who do you think you would perhaps advise? And I'm going to ask Dr. Urmila to give us a very her practical opinion here as to what would happen next.
I'd like to thank the panelists for all their opinion, and I actually agree with Dr. Jha and Dr. Valerie here. I will not offer transplant to him at all, because throughout his natural history, I have realized 15 years he has not gone and met a doctor, and then he gets into dialysis. And PD is actually, Priya, is to be done by the patient. You don't need a caregiver for a PD. And the first thing that we offer the patient when we offer them PD, we see that the patient himself knows how to do PD. We don't want 5 people, the wife, the brother-in-law, sister-in-law do PD. So there also he has actually inducted his wife to be the caregiver. Yeah. And he lost it. And why should a patient on PD lose his job? The very reason we ask them to do PD is to do a job. So we, in our practice, because there is again a problem, even in transplants. Priya, I agree with you, in our practice, this fellow gets a transplant, either his wife or his mother-in-law will give the kidney, and then all his medications every morning, evening will be given by his wife. Mm-hmm. And she will give his pills, then go to the farm, and then come back again in the afternoon and give his pills, and then again go back, cook, and then again come back and give his pills. I will not offer till I'm confident that he can take care of himself. So that's the first thing, my opinion. I'm sure he has donors, they can come. But this is a patient who has caused a lot of distress, financial distress to his family and to his caregiver. So even if you offer transplant, you and I come from a corporate hospital, we'll get the transplant done. And we'll save our patients also a lot of money, because he will not spend 25,000 INR on his PD anymore. Yeah. But I think first, Priya, we need to address this issue of his self-care. his understanding, his awareness of his kidney disease.
So I'm going to ask Dr. Sarla. I never expected actually, I guess maybe being a little naive, that I would always counsel my family that transplant is the best option, and perhaps I am definitely looking at it from a viewpoint of looking after children. So this is very interesting. So I'm going to ask Dr. Sarla, do you agree with what Dr. Urmila said?
Yes and no.
And why?
As I said in the chat, I would like to know various things about this gentleman. In fact, even before we started on dialysis, we'd have looked into why he has not accessed care for 15 years. For instance, a lot of our patients tell us that when they go to a clinic, they're told that they have hypertension, take these pills. And according to them, nobody says to them, this is a chronic condition. You've got to take pills all your life, and you've got to have, you know, your organs, your heart, your kidneys, whatever checked. So personally, we as nephrologists find that incredible that someone could treat a patient with diabetes or hypertension and not inform them that this is a chronic illness and that you need chronic care. But having seen how healthcare is delivered in many places, I believe it's really like a speed thing. You know, you can't really talk to your doctor, for instance, and they just told, take these pills. So maybe what the patients are telling us is fact. So we've grappled with that story as to why has someone got long-standing diabetes and hypertension. And quite often these people do go to clinics, but they've never had a blood test that we know of. And they suddenly crash landers on our dialysis program, having had diabetes for 20 years, and nobody's bothered to check, you know, have you got any kidney dysfunction? So who do we point fingers at there? The whole health system, the patient, the doctor, everybody. So that's the one point I would clear up. And the other point is, as I mentioned in the chat, all adult patients we accept must do self-care. We do not accept somebody who expects somebody to assist them with dialysis unless it's home dialysis, you know, home hemodialysis. And even then, one trains patients to be fairly independent. So as I said, it's only little children that one might expect the parent or an older sibling or someone to help, but otherwise patients must take care of themselves. And I would really want to know, why is this patient not doing well on PD? Is he skipping his exchanges? What's going on? Or has he got other problems, you know, complications, like is his anemia not being managed? Or has he got severe bone disease? Is there something that we can do to improve his physical situation? So, and if he's not doing his dialysis adequately, previously we actually used to send a social worker to visit patients every few months. And one of the things they do is look at the patient's stock. Or often our dialysis supplies are delivered to the patient's home. And if the supplier tells us that so-and-so has got a lot of supplies, and we never deliver more than a month's supply at a time. So if they've got a lot of stocks at home, that means they're not doing their treatment. So we intervene at that point. So if we find that someone's not carrying out their treatment, and we do intervene, we bring them in, we retrain them. And if they do not then adhere to treatment, one of the difficult things for us ethically is firstly choosing who we're going to treat, who we're not going to treat. And perhaps even more difficult, once you've taken someone on your program, is to say, I'm sorry, you'll have to go away. I'm not going to offer you treatment anymore. We have done that, but that second scenario is much rarer because our selection, our rationing process is very stringent to start with. So as I said, I was a bit ambivalent in my answer, but I think I would investigate the situation more carefully. And of course, if we have any concerns about whether the patient's adhering to treatment, then one wouldn't rush into dialysis. One would give them a 6-month period on dialysis to see, are they shaping up? And if they are shaping up, and we'll obviously have to see them on a monthly basis to see how well they are doing, and then one would embark on transplantation, because you feel that you don't want to, share the burden and let other people in the family get burdened with the problem.
Thank you, Dr. Sarla. I think you brought up really important points about investigating why this patient was being helpless, whether he was under-dialyzed or whether he just decided that he couldn't do anymore and he'd leave it all to everybody else to take care of him. Before I move on to our last scenario, which is pediatric, I'm going to ask Dr. Valerie. So I assume that everybody would say he needs a transplant. And in a high income setting, would this patient not be automatically assumed that he would move on to transplant and that would take care of the issue?
I think actually not. We do try to, especially, well, actually in both cases, I think living and deceased donors, because the point is a transplantation, even a deceased transplantation is taking a kidney potentially from someone else, and a living transplantation is taking a kidney from someone who may develop some harm from this at some point. So usually we do definitely try to assess that patients are adhering to their therapy. The question is how to measure that. And very often one uses, for example, phosphate. And I feel that's kind of unfair because a patient with a good appetite is actually healthy on dialysis and has a high phosphate. But I think as Sarala mentioned, are they actually doing the dialysis that's prescribed? Are they coming? Are they leaving early? Are they missing sessions, et cetera, et cetera? Some people then beg and say, yeah, because dialysis is so awful, I will be very rigorous with the transplantation. But there are patients then who suddenly decide to stop their medicine, and just decide they don't feel like taking pills anymore and things like that. So we don't want to get into those situations. So I have to say it's very awkward, but we do sort of try to decide, is this person worthy? They have to earn it to some degree, which sounds terrible, but it is a very scarce resource. And so we also need to be stewards of that resource as responsibly as possible. And in this case, there is an older, the mother-in-law who would have been my choice potentially as the donor because she's the one with potentially least harm. But in many cases, especially in your environment, I understand it's younger women who are not yet married and all this kind of thing. And it's very, very tough because their entire lives are then changed by this donation.
Thank you. That's enlightening. And I don't know if...
Can I make a point, Priya?
Yes, yes, sir.
So just 2 points very quickly. One is in response to Sarala's comment. In fact, I would say that I would have been very surprised if this patient had done well at PD, given this the knowledge of this patient's background that you provided, because it is inevitable that these patients will skip treatment, and even if they somehow spend money on the exchanges, they would perhaps cut corners with ancillary therapies that these patients will require. So I would have been stunned if with this background, this patient had done certainly well on PD and with his non-compliance history, etc. The second thing I would say is that I know that we are in the midst of highly accomplished nephrologists who work in tertiary care centers and so on. But I think we should stop becoming nephrologists. So we should stop becoming specialist nephrologists and we should become more social nephrologists and start first look at the socioeconomic situations of all our patients before making up any precipitate decision on what is best or not best for a given person. Now, we often pay lip service to shared decision making, but hardly ever do it because we are sort of making assumptions about why transplant is the best option or why one or the other type of dialysis must be given to this patient or the other. So that is what we need to do more of, and we need to destigmatize supportive care. Supportive care is not admission of loss. Supportive care is an active treatment option, which is the most appropriate for a large number of patients, right? And in the end, I think, again, even though we are talking about a disease condition, we need to demedicalize it to some extent. There are medical aspects of it, but there are huge aspects of patient care that are non-medical. And unless we do become aware of all of those, we would never provide optimal care to our entire ESKD population. Not every single patient with end-stage kidney failure is the same as the last patient or the next patient.
Thank you, sir. So I'm going to, before I skip to pediatrics, where I know Dr. Arpana and I will have plenty of opinions, I will open this question up to any of you. Who do you think then would be the ideal dialysis and transplant candidate? He's not so old. He's 50 years old. He's the sole breadwinner. I know that his family seems to look at him as the provider. He seems to have, I don't know whether he was non-compliant or whether he just wasn't aware that his hypertension should be treated, as Dr. Sarla was mentioning perhaps. And Dr. Lloyd was saying that it may just be lack of awareness. And so as Dr. Valerie was saying, these are very difficult decisions to make for the patient. And if, who would you say, go do dialysis and then let's do a transplant?
If I can kick off, Priya.
Yes, ma'am.
I would say I would defer with my good friend Vivek here, because a lot of our patients are exactly like this man, rural, breadwinners, bringing up young children, educating their children, and doing manual work. So one of the things I learned, just to say an anecdote, like the first patient, when I see a patient for the first time who comes in with kidney failure, I spend about an hour, more than 30 minutes talking to the patient, counseling them. And then part of our protocol was the patient goes afterwards to see the psychologist and the social worker, and they tell the social worker, the doctor didn't tell me anything. And I used to be thoroughly miffed that there I've spent a whole hour with this person. And he said, I haven't said anything to him. But I learned that, people are in such a state of shock when they come to you, severe uremia, and you say to them, you've got a terminal illness and you need this type of treatment, that they actually don't absorb it all. And therefore, I've had to sort of become humble and realize that people aren't sort of hanging on your every word and remembering every word you've said. And part of the education process is repeated education of the patient on different occasions with different people doing the education, the nurses, the social worker, the psychologist, the doctor. And therefore, you in the sort of education process, you're actually reinforcing adherence, actually. And if you find there's a problem, we often used to go into why is the person not being adherent? And I think we can retrieve a lot of patients. So therefore, as I said, for me, the most difficult thing is to turn off a patient once I've started them on treatment. And therefore, I would look very, very carefully. And as I said, generally, this type of patient tends to do very well because we find the more difficult ones. And I think the pediatricians on this panel would agree, probably the most difficult people to treat are the adolescents. The children are okay, the older people are okay, but the adolescents are actually very difficult to treat. So to me, this would be the ideal case, even though he's in a difficult situation and he hasn't been on treatment for hypertension.
Thank you. I see the various viewpoints here, and I agree with stressing the importance of counseling and maybe different team members other than the doctor working with the patient as well. So I'm going to move on. And this is just to, I think, reiterate what everyone was saying, that the minority really move on to kidney transplant. Dialysis is life-saving, but everybody with CKD, with kidney failure, is deserving and requires supportive care, both the patient as well as the family as well. And I agree with the point about the fact that mental illness is probably much more prevalent than we realize, both in patients and in caregivers. So switching gears now to pediatrics. So our patient is the 10-year-old girl with a late diagnosis of kidney failure from CACUT, congenital anomalies of the kidney and urinary tract. So her symptoms were poor growth and anemia only, and she had been taken to the primary care physician, but no evaluation was performed, as is very common. One blood transfusion was given and the patient was sent on her way. She was found to have bilateral renal hypodysplasia, that is small kidneys with loss of CMD. Maintenance dialysis was advised. The parents, however, were unwilling to accept the irreversibility of this diagnosis. As Dr. Sarla was saying, it comes as a shock to them. So they couldn't believe that their child had an irreversible disease. They requested more time to think about it and then left the hospital against medical advice. However, when the child developed seizures due to uremia, hypocalcemia, and hypertension, that's the classic triad that we see very often. And then she required to go to the ICU. In an emergent situation, they did agree finally that they would do maintenance dialysis and agreed to start PD. So this is a question that I will address, which is how is pediatric kidney failure different really from adults? And just to briefly touch upon how pediatric kidney disease is really different from adults. First of all, their diseases are non-glomerular, and so their symptoms are often, very often, as you can see in this case, missed by the parents. They are equally missed by the primary care physicians because these children are non-oliguric, and the only thing they present with are very chronic symptoms. So that's the symptom. So they finally, the majority of our patients with kidney failure present for the first time in kidney failure. Secondly, children are dependent on their caregivers, their parents, for medical decision-making. And so therefore, I think we in pediatric nephrology have to deal with both the child as well as the family. But it is, especially in India, I'm not sure how it is in, I expect it's similar in other low resource settings, is that in India, the parents have almost absolute authority over decision-making. If the parent decides that they don't want to do dialysis, there's nothing that we would do otherwise. And so often what happens is that if they decide against dialysis, like in this case, there is a discharge against medical advice, and we don't get the opportunity to even offer conservative care and maintain a relationship with the family. And I know this is very different in high-income countries where there are limits strictly drawn for the authority parents have over decision-making. If this was a high-income country, then the child would have been referred to social services because the family refused dialysis. So that's one setting that is different. However, there are very many similarities. We've briefly touched upon the fact that dialysis is expensive. In our situation, it is definitely the parent that does the dialysis. In most cases, it is the mother that does it. And so this leads to enormous caregiver burden as well. And we similarly, as you all were saying, have a lot of drop-off, discontinuation of dialysis and death. And this is something that I guess we as pediatric nephrologists find difficult to accept because none of this really, very simply put, is the child's fault. It is probably also not the family's fault as well. So,
Priya, if I can just jump in,
yes.
You just mentioned that loss to follow-up is one of our major problems, and we have published this. So I would be curious to know if this happens with you, Dr. Lloyd, in Africa, that patients just disappear.
Yes, because most patients, when they don't have funds, either they say they cannot do dialysis, or they may do a dialysis or two if it's an emergency situation and then just disappear. But children, by and large, we really don't have very many children, so we only have a little older children on dialysis, and mostly in Kenya, not in Rwanda and Tanzania. But I think key would be education of providers, getting them tuned to children, nutritionists, MDs, nurses, including biomeds, because the machine is different. You will need to have low flows, and the blood pump is also different with the whole tubing and things like that. So that is an issue. So yeah, do they drop out? Pediatric children, we have very few numbers, so it's difficult to comment. Adults, those even with insurance, people do drop out because they don't want, and in the family sometimes transport is an issue. They do drop out.
I think
Yes.
Important points, sir, because we've also experienced this, that it is not governed by finance alone, and there are many other factors that are responsible for patients disappearing and probably not continuing with any kind of care, and finally dying due to ESKD. Thanks, Priya.
And I was going to say, Dr. Lloyd, that I think the work that you do with the Africa Healthcare Network, I know you may be primarily dealing with adult disease, but I think that exact very same model of working with the grassroots, this hub and spoke education I think is really what we need to do in many low resource settings, because this late diagnosis, this child's diagnosis was missed, and that is a real tragedy. She was taken to a pediatrician probably, and the idea that the child would have kidney disease just didn't occur. So I think we would learn much from your model of spreading awareness of kidney disease in India too. So I'm going to wrap up very soon. I'm going to ask one last question. So pediatric kidney failure, pediatric kidney disease may be different from adults, but pediatric kidney failure, really the challenges are very similar. And so as you are all speaking, Professor Jha in your talk, and all of you, that we need to advocate for universal healthcare coverages in all its aspects, not just for dialysis. So how do we as pediatric nephrologists, do we join you at the table? How do we begin to advocate, and can we hitch a ride with you? I'll ask Dr. Valerie.
I have to say that now that I'm doing pediatrics, I really feel this is my new crusade.
You're converted to our cause.
No, I think both sides, because what I feel is interesting is that I'm informing my pediatric colleagues of a lot of things they don't necessarily think of. They don't always think this person will be 30 or 40 or 50 one day. They kind of aim at the transition sort of, and then like this will become someone else's problem. And definitely the adult doctors have no idea really about all these challenges. And then as Professor Sarala mentioned, this idea that the adolescents are so difficult, etc. Definitely they come as young adults then to our clinics, and then we're like, these people, they don't show up, why are they, they're so difficult. So I think we really need to learn from each other. And I've discussed this with Dr. Arpana about trying to really raise awareness. And I think through IPNA, you've been doing some of these joint webinars, which are fantastic, because I really do believe we have tons to learn from each other. I think it's enriching on both sides. And if we really are to accompany these patients across the life course, it needs to start with the obstetricians. Never mind the public health people, that there's a healthy woman at the beginning, but obstetricians all the way to the geriatricians. So I really feel absolutely, we all need to get together. It's not a competition, it's really a collaboration for true kidney health for all, which is World Kidney Day.
Thank you. So I'm going to just conclude these few slides that we have by basically going over the fact that accessibility includes availability, and as we've learned, not just about dialysis, but also conservative care and compassionate care. It needs to be affordable. We need to use innovative ideas in education and also in dialysis techniques. Awareness is required on behalf of the physician community as well as patients. The care that we provide needs to be acceptable, and it also needs to be equitably distributed. And above all, we need to advocate perhaps not just for universal healthcare coverage, payment funds, but also on behalf of the patient as well. So one more thing that I just wanted to conclude with was this comment on resilience. And I think it's been our observation among families that those who are determined to carry on, be independent, be adherent, ultimately probably prevail and have the best outcomes. So this was an interview that we conducted with the father of a child, 10-year-old child with kidney failure who had just started on dialysis. And the question was, how has dialysis affected the patient? And so it's in Hindi, but basically the father said that she is doing well. She's not scared. The child has a tutor. She's determined to continue her education. She loves to draw. And once her dialysis begins, then she just carries that dialysis bag around in her bicycle and only comes home during meals. And so the parents were both very positive that she was doing well.
वो साइंस का कोई भी डर नहीं है, वो तो ट्यूटर है, वो ड्राइंग करेगा, तो वो कनेक्शन दिया तो इधर पर से साइकिल चलेगा, खाना बनाया, वो साइंस का कोई भी डर नहीं है, तो ये अच्छे ठीक है, कोई भी प्रॉब्लम है.
And so if I were to explain resilience, it would be encompassed in this work of art. And so this is actually created by this same patient within a few days of her kidney transplant. And if you look closely, this she was in our ward when she made this. It's made out of grains of rice, which she colored green, and it's made out of lentils in orange. And that's all she used. She made this beautiful artwork with the rice and dal that was available to her because she didn't have access to any coloring materials. But she was determined, because she loved art, to create something beautiful. And I think that speaks about her resilience. And this was done, she is now 3 months post-transplant and actually doing really well. The donor was her mother. Finally, this is a picture from today's World Kidney Day celebrations among our children. And I just wanted to say that Kidney Care does take a team. We will see our social worker on the far right, our pediatric dialysis technician who's fabulous with children. We have a dialysis nurse, we have a transplant coordinator. And so though we are a bunch of nephrologists discussing this, we cannot thank our team enough. So that is the end of our my list of questions. I wanted to thank everybody for your valuable opinions and ideas that came up here. And I don't know if we have any time for questions, but I'll ask Dr. Arpana if there are anything that we can chat about.
I don't think we have any questions from the audience, but I would like to read out Dr. Jha's last chat note. Resilience is critical, but is put to test more than it needs to be because of the lack of resilience in our healthcare system. I think it's a very nice phrase to end this wonderful session on World Kidney Day. And we from the WIN India are grateful to each one of you for sparing time. And I think this is one of the best panel discussions we have had in a long time. It didn't give at least me the Zoom fatigue. And it's so nice to learn various experiences and perspectives of each one of you, coming from different backgrounds, but again, having a lot of common experience to share. Thank you, Dr. Jha. Thank you, Dr. Sarla. Thank you, Valerie. I know that you have been getting calls in between and still trying to manage chatting. So there are a lot of very nice inputs on the chat box. So I hope that one can, read through that and it doesn't disappear. So thank you. Dr. Urmila, would you like to thank everybody as the president of WIN? Thank you, Dr. Lloyd. Hand over to Dr. Urmila.
No, I think I thank Arpana, Priya, to have people who really have made a difference. And I thank you all. And this is perhaps one of the best meetings we had. We would like to get this from Priya and as a statement for us to sort of, in WIN India, how do we take this forward? Can you make the discussions that we had today?
Yes.
For you and me, Priya, it's like we offer treatment, patient can afford half of it, it continues. Yeah. We don't look into the other areas of it. So maybe it will help us guide in the future. and shared responsibility, shared day. So please, can you get this out as a small sort of a discussion, as a distill it into the areas and points that you have collected, so we can share it between our group.
Yes, ma'am. I think there was so much collective
Thank you,
wisdom
Professor
there.
Jha. Thank
And
you,
I know-
Devi. Thank you, Lloyd. Thank you, Sarla, madam. Thank you, Arpana, and thank you, Priya.
I know Dr. Jha will emphasize that, okay, this was nice, but what are you all going to do next? So it's nice to talk. It's nice to share our perspectives and opinion, but action is the next step. Like Dr. Valerie always puts it, action. We have to now implement, do something in our own ways to improvise and to go one step ahead. Thank you very much. Good night.
Thank you.
Thank you.
everyone.
Thank you to each and every one of you.
Yeah.